So we move now to our next presenter, Dr. Yazeed Alruthai. Dr. Yazeed is an associate professor of pharmacoeconomics and health policy. He earned his bachelor degree from Kingside University, a PharmD from Mass College of Pharmacy, and a PhD degree in pharmacoeconomics and policy from the University of Tennessee. Dr. Yazeed, inshallah, we're going to talk about the reference-based pricing in more details, and will give us more details about its implication, challenges, and action for pricing. So Dr. Yazeed, the mic is yours.
Thank you so much, Dr. Ahmed, for the nice introduction, and thank you so much, Dr. Nasser, for the actually excellent presentation. I don't feel I have much to add actually over what the previous speakers have actually talked about. So let me actually be quick and talk about a controversial, contentious, and highly politicized topic today. So I'm not going to be able to cover it thoroughly and fully. However, I'll try my best to touch base on important aspects of the external reference pricing. So my objectives for today's presentation first is to discuss the impact of pharmaceutical spending on the gross domestic product of different countries, provide an overview of external reference pricing practice in some countries, and thirdly, highlight some potential impacts of external reference pricing on prescription and non-prescription drugs affordability, availability, and its spillover effect. So without further ado, let's get started. So when the price of pharmaceutical is considered fair, actually it's really difficult formula to have or to balance to have a medication price in an affordable way for healthcare systems and patients, at the same time create some really or become profitable for pharmaceutical industry. So to have both actually or a win-win situation is possible. However, it's really challenging. So if we actually move to the pharmaceutical spending per capita globally, we can notice that the spending on pharmaceuticals ranges from 0.65% of the total GDP in Denmark, a wealthy country, to about 2.02% in Greece. Although Denmark is wealthier than Greece, however, its healthcare system is ranked interestingly lower than the Greece or the Greek healthcare system. But actually there's more to say about that as we're going to move forward and talk about how Greece adopted, and Denmark as well, adopted different techniques to contain costs and at the same time to or curb the increase in pharmaceutical spending, at the same time improve the quality of care. We'll see who actually is the winner there. So how much we're spending on pharmaceutical? If we look at 20 years back or 19 years back, we were spending globally $390 actually $1 billion in the year 2001. This figure was projected to be $1 trillion and $100 billion in 2016. Guess what? Did we reach that figure? I bet we actually exceeded that figure, but significantly. It's actually estimated to or projected to be $1.310 billion in 2020 this year. So the rate of pharmaceutical spending has increased significantly, which actually creates a really significant challenge to all healthcare system globally. So there's got to be something that we need to do to contain the cost and improve access to healthcare, especially pharmaceutical. So does public pharmaceutical spending impact GDP? This is a very controversial topic, and I had some debate with many of my colleagues who are saying that GDP has nothing to do with the pharmaceutical spending, some of them. However, there was a study that was published recently, almost a year ago, by two actually researchers in the Frankfurt School of Finance and Management, the Department of Economics, and they found that 1% increase in GDP per capita results in 1.4% increase in pharmaceutical spending, which says that the pharmaceutical spending is elastic, meaning or can be considered a luxury good. This is very interesting in comparison to other healthcare services, which is relatively inelastic. So in other words, if we increase the pharmaceutical spending by 1%, we can actually have a negative impact on our GDP per capita by 0.09%. So we need to curb the increase in drug prices and have different measures to contain the pharmaceutical spending, especially when we talk about highly priced medication like biologics and gene therapies. So what are the regulatory measures to curb monopoly power? We hear a lot about new medications are coming to the market, especially biologics, highly priced medication, gene therapies, medications for rare and ultra rare diseases. And the manufacturer actually or innovator has some monopolistic power. So we need to have some measures to curb their actually power and have something reasonable or a reasonable price for these different technologies, since pharmaceuticals are considered health technologies. So I'm not going to talk about clinical and cost effectiveness analysis, something that has been covered in previous presentations and is widely used in different agreements, entry agreements. There's also cost plus approach, which has been mentioned by Dr. Nasser Al-Qahtani, in which the pharmaceutical manufacturers are obligated to submit their the real cost of research and development, and then the regulator would add a fixed percentage as a profit for the companies, or a return on capital approach, which is also the regulator can control the return on investment or the profitability for the companies, but using a rate instead of fixed percentage. And lastly is external reference pricing, which is widely used globally, even in countries, European countries that pride themselves in using health technology assessment techniques. They still use ERB very widely. So what is international reference pricing or external reference pricing? International external reference pricing, also known as ERB, sometimes it's IRB, but just to avoid confusion with the internal reference pricing that has been mentioned by Dr. Nasser Al-Qahtani, I will use ERB, is a process of cost comparison through external reference or cross references. Compared to other models, which are based on evaluation of cost, profits, and effectiveness of drugs, the ERB is a very simple process. So you just compare the price that was submitted by the company to the prices in other countries, and ask the companies to submit price certificates in the countries upon which their products have already entered. So which countries implement IRB or ERB on pharmaceuticals? In Europe, ERB is implemented in 29 countries, including 26 of the EU member states, with the exception of United Kingdom and Sweden, TLV and NICE. They have health technology assessment bodies, also other European countries, but UK and Sweden, they use actually their health technology assessment techniques, and they highly believe in them. And UK is actually referenced as a country when we use ERB in the vast majority of the countries globally. ERB system was implemented in Canada in 1990. The ERB is also implemented in several Middle Eastern countries. So even Canada adopted ERB in the 1990s, although they also use health technology assessment techniques by the CADIT. ERB is implemented in several Middle Eastern countries, and I'm going to talk about that in more details in the next few slides. Every country has a reference basket. So, for example, in Jordan, they have 16 countries they reference. In Saudi Arabia, we have 30. In United Arab Emirates, we have 31. In Kuwait, we have only the country of origin. In Qatar, we have the country of origin plus 2 countries. So we have actually different baskets. Countries have different baskets, and they have their own criteria in selecting their baskets. So geographic proximity is one of the criteria upon which they select the countries that will be included in their ERB baskets. Comparable GDP levels, similar socioeconomic conditions, ad hoc considerations, like for example, favorable prices in certain countries. This actually might motivate the regulator to include those countries with favorable prices in the baskets of these countries. So what are the features or the key features of ERB or the external reference pricing? Selection of reference countries. So what are the criteria that you use to select the countries that you're going to include in your basket, and then you're going to use in implementing external reference pricing for any new entrant, any new pharmaceutical which going to enter your market. Flexibility in selecting reference prices. Are they very fixed in selecting the lowest or did they take the median, or did they take the average, or the mean, or they take actually the lowest 25th percentile, or the highest or upper 75th percentile, or the maximum or the minimum? There's got to be some flexibility there. Frequency of repricing. So how frequent are they pricing or revising the prices of the registered and approved pharmaceuticals? Is it every 6 months, every 1 year, every 2 years, every 3 years? Countries have different frequencies. Use of exchange rates. So do they consider especially in a highly movable markets? We're talking about, for example, the Saudi Riyal is tied up to the dollar. However, when we talk about the other European currencies, they're fluctuating. So some countries take the exchange rate into consideration when they use the ERB. Use of differential intellectual property protection expiry dates. For example, in certain countries, the M-patent pharmaceuticals expire sooner than the others. So if we use the countries upon which the pharmaceuticals or M-patent pharmaceuticals IP protection will expire soon, then we're going to have a lower price in our basket, and then we can select something more reasonable for our country. So ARB country basket, for example, Luxembourg, a country with a high GDP per capita over 100,000 dollars per capita, or GDP per capita. It uses the country of origin. It was also different countries, especially with favorable prices. We have Hungary and Poland. They have 31 countries they actually reference. We have Croatia. They have 5 countries. We have Portugal. They have 14 to 15 countries. So it's valuable. It's really valuable. What is the scope of IRB or RB application? It can be applied on all marketed drugs, like in Luxembourg, although it's a very wealthy country, they apply the ERB on all marketed drugs. In European unions, generally speaking, they use ARB and actually revising or pricing their publicly reimbursed drugs, especially in the transaction prices. In Germany and France, they use ARB for publicly reimbursed innovative drugs, and they take them into consideration, but not solely. ARB price levels, some countries use the ex-factory price, which is a price that is labeled by the manufacturer at the factory level. CIF price, which includes the freight and the insurance. Then they can use the pharmacy purchasing price, or which is a wholesale price, or they can use the pharmacy retail price. So, for example, in Saudi Arabia, they use ex-factory and CIF price, and the different Middle Eastern countries, they also use ex-factory and CIF price, in a different, I would say, rate. So what is the impact of ERB on pharmaceutical cost containment? The implementation of new ERB system in Slovakia, for example, in 2012 has resulted in a cost saving up to $85 million. How about Turkey? According to some expert interviews, they mentioned that it resulted in a cost saving of about $1 billion in the year of 2007. In Greece, they actually implemented ERB initially and resulted in cost saving. However, if you can recall the first few slides that I have touched base upon on the impact on the pharmaceutical spending as a percentage of GDP, Greece has the pharmaceutical spending accounted for about 2.02% of their total GDP. So they actually invoked or used the ERB in order to contain the rising cost of pharmaceutical spending, and in the short term, it resulted in cost saving. However, in the long term, it resulted in a higher utilization rate. So the lower prices were offset by the higher utilization rate and higher demand, especially that Greece has a national health insurance system. European countries that evaluate the prices regularly, sometimes every 6 months, had an average 6% lower prices. And we have to be concerned here about countries that revise their prices on a regular basis every 6 months. Yeah, they might actually enjoy a lower price, but this will result in actually bilateral trade. and can result in drug shortages. The impact of external reference pricing or international reference pricing on price levels for prescription medications. For example, Bulgaria, it has resulted in 37.7% discount compared to Moldova of 3%, Greece of 9.5%, and Netherlands of 8%. So it really resulted in a discount. However, the discounted price does not guarantee discounted spending on pharmaceutical. So what is the impact of international reference pricing on availability of prescription medication? It can result in market withdrawal, especially if we use the lowest countries in our prices in our basket. Launch delay of new products, new launch of new products. For example, new products will not be launched in certain markets because if they were launched in these markets that use ARB with the lowest price levels, they might actually resent their market sequencing strategies for multinational companies. It can result in a reduction in supply and drug shortages eventually. So there is an impact of ARB for sure in the availability of prescription medications. What is the impact of IRB or ARB on the availability also? The countries that they use or they don't use the ex-factory price level, they have the availability of prescription medication was actually okay, like in Germany, compared with countries that use ex-factory price level in their ARB strategy or method or approach. Delayed dossier submission in Belgium to prevent other countries from using Belgian price as a reference. So multinational companies use price market access sequencing, and they delay accessing the Belgian markets because they know if they access the Belgian market, actually it will result in lower prices, and then they will impact their access to different European and other high-income countries' market. Access delay of innovative drugs was witnessed in Slovakia after the country expanded its ARB basket to include all European Union member states. So companies became actually more reluctant to enter the Slovakian market. In Bulgaria, around 200 medications were withdrawn from the market in 2012. And why do you think that happened? Because Bulgaria used ARB and they enjoy lowest prices. So people actually go to Bulgaria for pharmaceutical tourism. So they actually import medication from Bulgaria to other countries. So companies decide to withdraw or delist some of their medications, especially generic medications, to actually control or stop the loss in their profits. What is the impact of ARB on equity? Let's talk about Austria with a GDP per capita over $50,000 per capita. It uses Pakistan of $1,130 GDP per capita. It uses Ukraine of about $3,000, Romania of about $10,000, Bulgaria of about $8,000 or $9,000 per capita. So Austria, a wealthy country, uses these countries in its basket and actually pricing the new generic as well as brand medications. So there is some issue with the equity, and I'm going to talk about that in the next few slides as well. The impact of international reference pricing on industrial policy, reduction in the industry's revenues. For example, in Slovakia, the European Generic Medicines Associations, also known as EGA, decided to withdraw olanzapine as an example because Slovakia was a very favorable place for parallel trade. People were going to Slovakia to buy their cheap generic medications, which really limits the profits for the generic manufacturers in Europe. So it serves sometimes as a disincentive for research and development investment based on the views of the generic manufacturers. So how to avoid that? We need to select countries that recognize value of innovation. For example, countries that use HTA, different HTA techniques to evaluate pharmaceuticals and assign a value or incremental value in every new entrance to the market. So what is the impact of ARB or IRB on price stability? A systematic price revision every year has been estimated to lead to price decrease at a double rate compared to every 3 years revision. So the more frequent you revise a price, the better actually prices. However, this might impact the equity as well as the availability. So you need to balance the different factors. It has been estimated that a €1 decrease in drugs prices in Germany will result in 0.09 euro reduction in price in Austria due to direct effect, as well as 0.15 to 0.19 euros due to an indirect effect. So there's a spillover effect. If you reduce a price in one country, it will have a spillover effect in other countries, especially countries with geographic proximity. The practice of agreeing to confidential rebates have an external effect since ARB use may not reflect the transactional prices. In Germany, sometimes the regulator there, the IQWIG or the CT, they will have, or the German Federal Committee, they will have some sort of agreement with the pharmaceuticals. So they give the pharmaceutical companies a really favorable list price. In return, the pharmaceutical companies will give a confidential rebate or discount actually to the health or sickness funds in Germany. Sorry. Let's talk about the Middle East. There was a study that discussed the impact of IRB or ARB on price convergence, and they included 7 countries: Qatar, United Arab Emirates, Kuwait, Saudi Arabia, Lebanon, Jordan, Egypt, with different GDP per capita. What did they find? They find that the price actually, if you see my cursor here, the price corridor of all drugs in comparison to non-pharmaceutical services and non-diagnostic services and diagnostic services is actually very narrow. So there is a price convergence here, which means that some countries with low GDP per capita are getting a price which does not account for their population sizes, does not account for their GDP per capita, does not account for their ability to pay. So, and it does not actually correlate with the spending or the price corridor for other healthcare services, which is something which is a concerning thing about the equity here. So what is the impact of IRB or RB on launch sequencing? A launch delay is defined as months between or years sometimes between the drug's first global launch and launch in specific country. For example, in certain European markets, there was an average delay of launching unpatented or unpatented diabetes drugs in months. So in Switzerland, it takes about 1 month after the approval of that new pharmaceutical for diabetes to enter the Switzerland market. In Sweden, it's about 5 months. Think about Croatia, that uses 5 countries with low actually ERB prices. It takes about 36 months, so almost 3 years to enter the market, which actually impacts the access to innovative treatment. How much can be saved if ARB for Medicare Part D, which is actually Medicare Part D is a segment of the Medicare insurance, which is insurance for those who are above 65 years of age in the United States, and also for patients with a chronic kidney disease. So Medicare Part D is the part of insurance that provides coverage for pharmaceuticals, especially outpatient pharmaceuticals, inpatients covered by Medicare Part B, outpatients covered by Medicare Part D. And it was implemented back in 2006. So the United States is very actually important market because it represents about 48% of the global pharmaceutical spending on pharmaceuticals. So any actually intervention, any adoption of ERB by the United States will, one way or another, impact the global pharmaceutical prices directly or indirectly. So there was a study by different researchers in Bloomberg, and what they find actually that if the United States Medicare Part D implemented external reference pricing using UK, Japan, and Ontario in Canada, which is the most populous actually province in Canada, they found that the price differential between the United States and the UK, United States and Japan, and the United States and Ontario in Canada for 79 single source brand name drugs is about 3.6 times the price in UK. So the price in the US is 3.6 times the price in the UK, 3.2 times the price in Japan, 4.1 times the price in Ontario in Canada. And the more the single source brand medication stays in the market, the more likely the differential will be higher. So these medications that were selected were actually approved for more than 3 years, for 3 years or more. And even though they found that their prices, even after the rebate, so it's understood or well known that Medicare Part D gets about 17.5 to 35.4 rebate from the pharmaceuticals once they approve their medication in their formulary. However, despite of the fact that we have control for that, this actually did not, the differential was very high. So if the Medicare Part D implemented ARB, it will result in about $72.9 billion saving in the year 2018 alone. And this study was published back in 2019, just a year ago.
Two more minutes, Dr. Yazeed, if you don't
I'm
mind.
actually wrapping up,
Okay.
Dr. Ahmed. So other researchers in the United States believe that the United States should not go that route, and international reference pricing is a lazy, misguided, bipartisan plan. And they believe, although there could be savings, which amounts about $80 billion or $70 billion, as I mentioned, as I actually discussed in the previous slide, this actually plan is not effective in the long term, and they called for the implementation of health technology assessment in the United States. We should actually govern or control the prices for the different publicly insured patients, either Medicare or Medicaid or the state children health insurance program. So I'm going to leave you with some food for thought. So is it fair to charge a patient more than he or she can afford for a prescription drug? Think about it. Is it fair to expect that a payment to include the charge to fund research and development for the inventor, so we subsidize the industry? Should confidential prices with governments be made public, so we have more transparent, actually, ARB prices? Should research and development be paid by the governments and limit the role of companies to manufacturers? I mean, one way of socializing the manufacturing of medication. Should drug companies be first to show development costs for each drug? Well, it's food for thought. Think about it. So to wrap up, the revenues of the pharmaceutical companies can be influenced by the market selected to launch their products. Therefore, we see some market access delay in certain markets. The manufacturers can decide not to launch their product in particular markets, especially with low-income country, which actually impacts patient accessibility to care. The ERB has been applied on almost all developed nations, with the exception of Sweden and UK, but grant you even nice sometimes look at the prices in different actually countries, and they included confidentially in their assessment of different pharmaceuticals. ERB may have a negative impact on patient access to essential medications, and market sequencing is one of the strategies companies use to deal with ERB. So with that, I'll leave you with the questions, and thank you so much, Dr. Ahmed, Dr. Nasser, and the organizing committee for the invitation. And I hope I addressed that topic in a good way. Thank you.